Hi, and welcome to AIDS 2020. My name is Greg Millett. I am the Vice President of AMFAR, as well as Director of Public Policy, and I'm looking forward to speaking with you today about casualties on the road to ending HIV. Context matters in addressing HIV disparities. So to make sure that we're all on the same page, I want to talk about what the word disparity means. Disparity is the condition or fact of being unequal, as in age, rank, or degree, or difference. We certainly see those disparities when it comes to the US epidemic. These are data from the Centers for Disease Control, which show that among those individuals who are diagnosed, it's most likely communities of color, as well as men who have sex with men, who are likely to be diagnosed with HIV. Now, we also see that there are some conundrums with HIV diagnoses. Even though we see higher rates of HIV in African American communities, it's not necessarily reflecting higher risk behaviors. These are data from about 20,000 young adults who are followed, and the blue bars are people who engaged in low risk, who are white young adults. The red bars are people who engaged in high risk behavior, and you can see with the red bars, those are the individuals who actually had HIV or an STD. When they compared them to African Americans, you saw that it doesn't matter if you engaged in low risk or high risk, that African Americans are more likely to have these red bars, meaning that they're more likely to have HIV or an STD. We found similar data for studies that I used to do when I was at the Centers for Disease Control, comparing Black gay men with white gay men, where you could see that overall Black gay men compared in similar rates of unprotected anal intercourse as compared to white gay men, had fewer sex partners across studies, but still more likely to have an STD. We saw the same thing in a follow-up analysis 5 years later, where Black gay men engaged in similar rates of serodiscordant unprotected anal intercourse, had fewer sex partners, but still higher likelihood of viral STI. So these disparities are somehow fueling HIV among African American communities, even though African American communities don't engage in high rates of risk behavior. Now, last year, President Trump announced an initiative to end HIV in the United States by 2030. It's a 10-year initiative where the first 5 years are focusing on 48 high-burden counties, including Washington, D.C. and San Juan, Puerto Rico, as well as 7 states with a high rural burden. The good thing about this initiative is that they're focusing on communities who are high risk for HIV. So they're focusing on African American communities, Latino communities, Native American communities, gay and bisexual men. And they're also scaling up interventions to address HIV in these communities. Now, part of the talk that I wanted to have with you today is what are some of the things that might derail efforts to address the Ending the HIV/AIDS Epidemic Initiative, or EHE? Well, the first is unforeseen events or trends. And part of that is what we're going through right now with COVID-19. The fact that we're having a virtual conference is because of COVID-19. COVID-19 arrived in the United States in January, and you can already see that there were some racial differences taking place in diagnoses. These are data from Mississippi as well as Shelby County, Tennessee. And despite that African Americans were 38% of the population in Mississippi, they were 59% of cases and 62% of deaths. To the right of this, you can see is a map of those counties that are at least 13% African American in the United States and what COVID-19 diagnoses look like there. And you can see that these counties are primarily centered in the southern United States. And I want to talk a little bit more about that a little bit later. My colleagues and I published a study. These were colleagues from Johns Hopkins, Emory University, University of Mississippi, as well as Georgetown University and PATH. We all published a study recently looking at COVID-19 in African Americans because there were no national data to see what's happening in Black communities. And what we found is that even though Black counties were only 22% of counties in the United States, they accounted for 50%, over 50% of coronavirus diagnoses, as well as 58% of deaths. And what we found is that as the number of African Americans increased in a county, you saw increases in COVID-19 cases as well as deaths. However, we also found that underlying health conditions such as diabetes, heart disease, etc., were not associated with COVID-19 cases or deaths, that it was more the social determinants of health such as unemployment, access to health care, as well as number of people who are in a household. Now, past is definitely prologue when it comes to the epidemic that we're seeing right now for COVID-19. We saw the swine flu back in 2009 and 2010, and these are data from CDC where it showed that swine flu disproportionately impacted communities of color, where they saw that Blacks, Latinos, Asians, as well as American Indians were more likely to be hospitalized with swine flu. When you take a look at COVID-19 and what's taking place here right now in the United States, If you look at counties that are primarily white, these are counties that are at least 67, 68% white, you find that those counties, compared to counties that are primarily communities of color, are far less likely to have COVID-19 all the way through today. And they are also far less likely to die from COVID-19. And you see these numbers as well, even in the moving average, the 7-day moving average, where you see less COVID-19 in many of these counties. And even though we're seeing an increase, the increase is not as high in these counties that are primarily white compared to counties that are primarily Black or Latino or Native American. So this is a racialized disease, and we need to figure out why these disparities are taking place for COVID-19, just like we see the disparities for HIV. And one other thing that I'd like to point out is just because you see a disparity doesn't mean those disparities are static. We know that the opioid epidemic is more likely to affect white Americans in the United States. And these are data from CDC that showed from 2005 to 2015, the proportion of new injectors in the United States were becoming more and more white and less Black. And part of the reason for this is because we know that doctors are far less likely to prescribe opioids to African Americans, mainly because of racism and other issues, as compared to white Americans. So opioids and opioid deaths primarily affect whites in the United States as compared to African Americans. But just because we're seeing that dynamic doesn't mean that it's going to be static. And I want to explain to you why. We've seen that when it comes to drug use among gay men, that Black gay men are far less likely to use drugs as compared to white gay men. And this is from a paper that colleagues and I published years ago, where you look across studies that Black gay men are far less likely to report using drug use compared to white gay men. And crystal methamphetamine, we know, is associated with HIV in the United States. People who take crystal meth are at higher risk for HIV. Here, where I live in Washington, D.C., you see that crystal meth usage rates have actually been decreasing among white gay men between 2008 and 2014. But we're seeing this increase among Black gay men during that period of time. So even though we saw less crystal meth use at some point with a lot of these national studies, at another point in time, we're starting to see more crystal meth use in these communities. And we're probably going to see the same thing when it comes to opioids in African Americans. As a matter of fact, right now in Washington, D.C., most of the individuals who actually die from opioid use and opioid deaths is among African Americans. And that's part of the reason that we need to take a look at some of these other issues that are associated with some of these disparities. And one of those issues really is the social determinants of health. Now, these are issues like income, unemployment, other issues that might be associated to health that might explain some of these disparities that we see. And we see that there's plausible reason for that. There was a study that was done that were looking at 80 cities in the United States over a 10-year period to see what social indicators were associated with new HIV infections. And what they found was income inequality, families in poverty, or the percentage of segregation, Black-white segregation, were all associated with more HIV infections within particular communities. And when you wanted to take a look at Black communities, what was associated with new HIV infection was poverty, vacant housing, unemployment, as well as isolation of these communities, segregation of these communities. And that last point, I want to just show you what that looks like for not only HIV, but for STD. Now, these are data that colleagues at the Center for Disease Control published years ago, looking at the distribution of chlamydia as well as gonorrhea cases in the United States for those places that have at least 80% white American. And you can see that the distribution is all over the US. When they looked at those places that were at least 15% African American, you see that the distribution was concentrated in the southern United States. We have these dense distributions of chlamydia infection as well as gonorrhea. The same distribution that we saw with COVID-19 when I showed you those maps a little bit earlier in our presentation. So this is something that we know that is perhaps driving some of these disparities that we're seeing among African Americans. Now, a lot of people like to talk when it comes to COVID-19 about these underlying health conditions like heart disease as well as diabetes. And sure, we see higher rates of these among African American counties in those places that are disproportionately African American. But more importantly, we see higher rates of these social determinants of health, such as poverty, unemployment, uninsurance. And these are some of the issues, just like with HIV, that might be driving some of these disparities that we're seeing in these areas. Another thing that we see that adds to disparities for COVID-19 is the issue of wealth and privilege. These are maps from New York City. And what you can see here is these are data from the New York City Department of Health, where the lighter indicates fewer COVID-19 positive test results. So compared to the rest of the US, these places in Manhattan had fewer COVID-19 test results. When you take a look at those same places to see how many residents actually left Manhattan or the city between March 1st and May 1st, you see that a large proportion of individuals here in this dark red actually left the city because of COVID-19 and trying to get away from COVID-19 risk. They actually found in this study from the New York Times that 40% of these residents left the city to escape COVID-19. And because they left, they were less likely to be at risk for COVID-19 when it was high in the New York City area. The individuals who remained in many of these areas were at higher risk for COVID-19, and you saw greater COVID-19 diagnoses, as you can see on the map on the left. So that's about wealth and privilege. And we see wealth and privilege also operating with HIV and associations with HIV. Now, gentrification is taking place in many parts of the United States. And this was a study in San Francisco that was looking at the proportion of individuals who are leaving who are HIV positive from San Francisco. And what they found is that over 2006 to 2014, that the number of HIV positive white gay men who left was about 200 or so men, give or take. For HIV positive black gay men, they saw that about 400, nearly 500 of these men actually left the city of San Francisco. So there's this out-migration of the community that's at highest risk for HIV. And we know that San Francisco is in the middle of an effort to end HIV, and they are making significant gains, which is great. But part of the reason that they're making those gains is that the community that's at highest risk for HIV no longer lives in San Francisco and is elsewhere. And this is not just operating in San Francisco. This is happening in Chicago. It's happening here in Washington, D.C. It's happening in New York and other places that also have end AIDS efforts. But those efforts are somewhat driven by the fact that these communities can no longer afford to live there and they're moving elsewhere. So we're exporting our epidemic. We also have similar issues with COVID-19 and economic losses and its impact on the Black community. These economic losses are not borne equally for COVID-19. So even though we see these 40 million Americans who are out of work, the unemployment rate is much higher for African Americans as well as Latinos as compared to whites. And even though there's a small dip in unemployment for white Americans, we see that there's a small increase that took place for African Americans. And what many people are bracing for right now with so many people out of work, particularly in the Black community, is mass evictions. African Americans are more likely to rent as compared to white Americans, and we're probably going to see mass evictions and greater degrees of homelessness that could also be associated with HIV risk, and I'll talk to you about that a little bit later. But one of the other big things that we're seeing as well is Black-owned businesses are being devastated by the COVID-19 epidemic. As many as 40% of Black-owned businesses are not expected to survive. This is a study that was done by Stanford. And it's not just Black-owned businesses. We're seeing that among immigrants, a high number, as well as Latinx-owned businesses and Asian businesses are less likely to survive because of COVID-19 as compared to a much lower number for white-owned businesses. So even this devastation that we're seeing in the economy and the businesses that are owned by various people, that there's a racial disparity and dynamic that's there. And part of this really feeds into other research studies that have found that in those countries where we see a high level of income inequality, that you see also a high number of health and social problems. And this was a study that was done by Farley in 2013, where you could see among Western industrialized nations, the USA was at the top for having high levels of income inequality, as well as health and social problems as part of that. And that's something that we are witnessing, certainly with COVID-19, and something that we've seen for quite some time with HIV. Now, I did mention that I was going to get back to the whole issue of homelessness. When we take a look at the ending HIV epidemic, and you take a look at those localities, those 50 localities who are part of the EHE, you find that they have higher levels of homelessness as compared to the national average. And that certainly has consequences. There was a fantastic study that was done in San Francisco where they looked at homeless populations and those populations who are renting to own, all the way down to those individuals who were sleeping outdoors. And these are individuals who are all HIV positive. And what they found is that individuals who are sleeping outdoors were less likely to be virally suppressed. And they were also more likely to have a median viral load that was high. So you could see this degree from people who were in treatment centers or an SRO or a hotel or sleeping at a friend's place or in a shelter, all the way to sleeping outdoors. We saw this decrease in viral load. So homelessness is associated with poor health outcomes for people living with HIV. And we know that that's going to be an issue in this era now with COVID-19 and this recession that we're seeing that's going to be borne unequally in Black and brown communities. There are also data looking at the treatment cascade for Black transgender women and the social determinants of health, where they saw for transgender women, only about a quarter of them were virally suppressed. And one of the reasons why these Black transgender women were not virally suppressed was homelessness. So again, the social determinants of health that are associated with greater disease within specific communities, particularly minority communities. And I found the same thing as well in a study that I had done looking at Black gay men who are HIV positive compared to white gay men who are HIV positive, where we saw all through the treatment cascade these pronounced and statistically significant disparities all the way down to viral suppression. And what was really driving it, again, were these social determinants of health, where HIV positive Black gay men were 3.5 times likely to have a lower income compared to HIV positive white gay men, and they were about 50% less likely to have access to health insurance. So what does this mean in terms of policy? What are some of the associations that we might see with policy in health? Well, one of my favorite quotes is a quote from William Faulkner that says, "The past is never dead. In fact, it's not even past." And we certainly see that with the geography of many of these diseases in the United States. I showed you HIV diagnoses in the United States among African Americans, where African Americans are at least 13% of the population, primarily located in the southern United States. You see the same thing with COVID-19 diagnoses. You see the same thing with diabetes and many other chronic health conditions as well. These are also places where we also don't see expansion of Medicaid, a policy as part of the Affordable Care Act that gives insurance to many more lower income people in the US. And 5 of the 7 states that are part of EHE have not expanded Medicaid. And that's a problem because we know that Medicaid expansion is associated with greater HIV testing. It's associated with greater access to opioid treatment. It's also associated with greater sustained viral suppression among people living with HIV. Yet these states have not expanded Medicaid. And we also know too that Medicaid expansion is associated with access to PrEP. So those places that have not expanded Medicaid have less access to PrEP as compared to those places that have expanded Medicaid. And even in those EHE districts that have not expanded Medicaid, see how there's fewer access to PrEP as compared to those localities that have expanded Medicaid. We also see in those states that are a part of EHE that we have high rates of people who are not insured. And I had already showed to you that high rates of uninsurance is not only associated with greater rates of HIV, but also greater rates of COVID-19. And you could see that it doesn't matter by what race or ethnicity, white, Asian, all the way to Latinx, Native American, African American, et cetera, that these 7 states that are part of EHE have high rates of uninsurance. The last thing that I want to talk about too is that there's an issue in terms of the geography where we find the greatest number of African Americans. About 55% of the African American community resides in the southern United States. And those are the part of the places where I was showing you in many of these maps where we see high rates of chronic conditions and other health conditions among African Americans, as well as policies that are really problematic that are not helping in terms of health. There was a paper that was done that was looking at the political legacy of American slavery. And what they found is that in those states in the South that had a higher proportion of slaves in 1860, this is what you could see in the darker red here. In those places, whites in those places were more likely to be conservative, were less likely to have warm feelings towards African Americans as compared to whites in other places that had fewer slaves from 1860. And that the policy in those places as well were policies that really aggravated the disparities among African Americans compared to other groups. And it's not just in the South. We see that there's some systemic biases that are concerned with new technology and who gets access to new technology once we have it. For COVID-19, there have been several studies that have found that in Tennessee, in Texas, in Philadelphia, in New York City, that even though African Americans were more likely to be diagnosed positive with COVID-19 testing centers were less likely to take place or to be located in African American or in Latino communities. We see exactly the same thing, unfortunately, with HIV. When antiretroviral therapy became available, we saw that the disparity in mortality rates actually increased between African Americans and whites during the time when ART became available. And that's because African Americans had less access to antiretroviral therapy and thus were more likely to die. We're seeing the same thing now today with pre-exposure prophylaxis, which keeps people from getting HIV if they take a pill a day, where African Americans as well as Latinos, even though they are both more likely to be at risk for HIV, are less likely to have access to pre-exposure prophylaxis. And this bias is systemic. There was a New England Journal of Medicine article that was just published recently that showed that many medical decision-making tools actually disadvantage African Americans. Algorithms that they use for various transplants actually disadvantage giving some of this medical help to African Americans as compared to other groups. And there was another paper that was published by Levine that was taking a look at Black-white disparities in mortality and laws in the United States across various health conditions. And what they found is that federal laws promote increased Black-white mortality by inadvertently favoring whites with respect to access to life-saving innovations. Failure of legislation to address known social factors is a plausible explanation, at least in part, for some of the observed disparities that we are seeing. So we're seeing this systematic bias taking place in policy as well as in medical settings. Now, what does this mean for people living with HIV? There was a wonderful paper that was published earlier this year by Michael Mogavero and his colleagues in Alabama, where they were looking at people who are living with HIV in their clinic and to see of those who had a greater number of traumatic or stressful events, whether or not that affected viral suppression. And you could see here that those individuals who reported more stressful events or more traumatic events were less likely to adhere to their regimens, were less likely to be virally suppressed. What does that mean for implementation of ending the HIV epidemic in our current policy landscape, where we see that there are attacks from the highest levels of government against transgender populations, against women of color and access to healthcare, against LGBT populations and making sure that they're not discriminated against in various places from the military, including work, to what's taking place with immigrant communities and the policy landscape there. There are many issues that are taking place right now policy-wise that's going to make it hard for us to implement EHE because the communities at highest risk for HIV are being assaulted by policies that are not helpful for their health. And what does that mean in terms of sustained viral suppression? CDC took a look at data for African Americans across all groups, whether or not they were male, female, youth, men who have sex with men, or people who inject drugs. And they found that sustained viral suppression was always less in those groups that were African American. What is that? Is that a part of some of these policies and systemic biases that we're seeing that makes it hard for people who are living with HIV to get virally suppressed? And of course, there's a blowback that's associated with all of this as well, and these systemic biases. We know that African Americans are less likely to trust healthcare professionals. African Americans are more likely to believe that HIV is a man-made disease, that HIV information is being held back from the public, that there's a cure out there that's being held back from the public. And we know that people who subscribe to these beliefs are less likely to test for HIV, and they're less likely to take their medications or to be virally suppressed if they subscribe to these beliefs. Unfortunately, we're seeing the same thing for African Americans and the coronavirus and whether or not we have a vaccine available for coronavirus, where more African Americans are actually skeptical about the COVID-19 vaccine. And a lot of that is predicated upon these systemic biases that these communities have suffered in the past, where they're less likely to trust the medical community. So how do we overcome these disparities? The good thing is that we can overcome them. There has been some remarkable work that's been done from some of our federal partners. This is from the Ryan White program, where they've seen these year-on-year decreases in viral suppression among African Americans and really limiting that disparity that we see in viral suppression in the Ryan White program between African Americans as well as whites. Also, in the Veterans Administration, we see a minimization of some of these disparities as well for HIV, but we're also seeing it for COVID-19. This is part of a paper that hasn't been published yet. It's in MedArchive, where they looked at 6,000 veterans, and they found that COVID-19 cases were elevated for African Americans and Latinos, but there were no differences in deaths by race or ethnicity. Let me repeat that. no differences by race or ethnicity in COVID-19 deaths among these 6,000 veterans. And why that's important is because we know that in the Veterans Administration, there's more health equity. There's more to trying to stamp out some of these systematic biases in delivery of healthcare. And that might be part of the reason why we're not seeing elevated deaths of COVID-19 for African Americans or Latinos. Another thing that we could do to address disparities is we have to center marginalized communities. My colleagues and I wrote a brief where we asked rhetorically in 2015, do Black gay lives matter? And back then, we really didn't think so because there were such high rates of HIV among Black gay men and very little that was being done systemically in terms of policy to address that. Things have actually changed since then. There were few white Americans who really subscribed to the belief of supporting the Black Lives Matter movement. That's changed now. Now, after the death of George Floyd and many others, you've seen this complete shift in sensibility where a majority of white Americans, Black Americans, Latino Americans, and Asians support the Black Lives Matter movement. And one of the things that was really one of the happiest things that I've seen lately was in my old neighborhood, 2 blocks from where I grew up in Brooklyn, there was a rally for thousands of people in support of trans Black women's lives and saying that their lives matter as well. A community that's not only been devastated by HIV, but also savage violence that's been leveled against it. So we are at a turning point right now in the United States that could somehow translate into policy. We're certainly seeing it translate into some of the decisions that are being held at the Supreme Court. Recently, we had a Supreme Court decision that says that gay and transgender workers are protected by federal law, barring discrimination. We also saw that the Supreme Court blocked the administration's effort to wind down the DACA program and to make sure that many of those individuals are able to remain here in the United States. So these are things that are important. These are communities that are at higher risk for HIV, where we're actually seeing some protections under the law. The last reason why I think that we can not only address HIV disparities, but COVID-19 is because we know that there's a strong community response for doing so. So right now, there's a lot of nostalgia in terms of the early days of HIV and how scientists across the world, all of us, came together to really systematically address HIV. And we did. We've done a wonderful job in addressing HIV both domestically and globally, despite the fact that we still have these disparities. We've still made a lot of progress. And that's part of the reason why these HIV scientists are at the forefront for COVID-19, with the New York Times saying that this is a seminal moment for scientists. Remember that these gains that we made is not just because of all of us in the scientific community. The gains that we made was because we worked in conjunction with communities at risk for HIV. And that is what's going to defeat not only HIV, but COVID-19. We need to make sure that communities are at the center of the response and at the center of providing solutions for some of these health crises that we are seeing. I wanted to thank you for your attention. This is my email and how you can reach me. I also want to remind you that there is a Lancet series, HIV in the United States, that goes more in depth about some of the disparities that I talked about today, where you can gain additional information. And then, of course, no person is an island. There were a lot of people whose work that I borrowed from to help pull together this plenary, and I just wanted to thank them for their incredible work and for contributing to my talk. Thank you.